Moving on to the next session, that's on events of early pregnancy. We begin our session with early pregnancy imaging by Dr. Sridevi. Sridevi is graduated from JS Medical College, Davangere, MS from JIM Medical College, Mysore, Assistant Professor, Department of Obstetric and Gynecology from Sri Ramchandra Medical College, Chennai, done her fellowship in medicine from Mediscan, Chennai, advanced obstetric ultrasonic training in UK, RCOG, Best Paper Award on Malaria in Pregnancy in 2002, and Almudiliar Fellowship in 2005, Best Paper Award for Transverse Facial Cleft in 2012, and now currently consultant at Krishna IVF Clinic. I welcome you, Dr. Sridevi, for your lecture.
Very good morning. The topic for me today is early pregnancy imaging. I'll be talking about the location of pregnancy, assess the viability, assessment of the gestational age, and the number. Especially if it is more than one, we have to know about the chorionicity and amnionicity and the detection of anomalies. So to start with, an early pregnancy imaging should be always a transabdominal, and it should be followed by transvaginal, and this requires an optimal bladder filling. What actually this optimal bladder filling means, the bladder should be full up to the fundus of the uterus. This should not be difficult for an early pregnant lady because usually the problem is the nausea and vomiting. So once you see the uterus and the sac, don't jump into the first sign of the gestational sac. Instead, you have to see the overview of the uterus and the surrounding structures, and you have to utilize the opportunity to see the true and false pelvis by transabdominal scan. So the first thing to see in early pregnancy is the gestational sac, and the gestational sac, it is always better to see in an axial view. So here you can see the gestational sac and the fluid in the cavity. This chorionic tissue around the sac, which gets embedded in the endometrial junction, is the decidua basalis, and the surrounding one, which around the sac, is the decidua capsularis. The rest of the decidual endometrium is called as the decidua parietalis. Regularly, we don't see this kind of picture. This is seen here clearly because there is some amount of fluid in the endometrial canal. The counter of the gestational sac is usually circular, sometimes sausage shaped, but it won't be never like this, irregular. So once we see the gestational sac, we try to measure the sac. The rules apply here also. We should not measure this white area. This is called as the chorionic reaction. This differs from sac to sac and from pregnancy to pregnancy. So once you're measuring, you have to measure inner to inner measurement. And once there is a sac more than one, then you have to start counting the number of sacs. This helps us in pointing out the chorionicity. So here, early pregnancy, here you can see just by eyeballing that this is a dichorionic pregnancy. So as the pregnancy advances, the thickness of the intertwin membrane decreases, and sometimes at term, if the patient comes without the labeling, we won't be knowing whether this is a monochorionic or dichorionic pregnancy because the whole management depends upon the chorionicity of that pregnancy. So we can see here triplets, quadruplets, and quintuplets. So can we call this as trichorionic triplets or quadrichorionic quadruplets? No. The ideal time to say or to name the twins is 8 to 10 weeks, and we have to see further inside the sac to start labeling the twins. The next structure we see is the yolk sac. You can see here the yolk sac is always an extra amniotic structure. We can see here this is the yolk sac, this is the amniotic sac, and this is called as the extra embryonic coelomic space, which gets obliterated by 13 weeks. As the amniotic fluid increases, this amniotic cavity increases in size, gets fused with the chorion, and this space completely gets obliterated by 13 weeks. And we can see here yolk sac is connected with the yolk stalk, And this is a 3D picture where we can see the yolk sac is connected to the base of the cord. So what is the importance of seeing the yolk sac in early pregnancy? The yolk sac tells about the amnionicity of that particular pregnancy. So you can see here 2 sacs and 2 yolk sacs. So this is a dichorionic, diamniotic twin pregnancy. Here there's a single sac but 2 yolk sacs. So this is a monochorionic, diamniotic twin pregnancy. But here we are seeing 2 sacs, but in one sac there are 2 yolk sacs. So this is a dichorionic because only 2 sacs, but the number of amnionicity is going to increase as a triamniotic triplets. And this one sac with 2 yolk sac, but there is a lot of discrepancy in the size of the yolk sac. This also should be considered once it is more than 6 millimeters. And here we are seeing a single sac, 2 fetuses, but only a single yolk sac. And this single sac, 2 fetuses, single yolk sac, this is the monochorionic, monoamniotic twins. Here you are seeing a 1 sac, but 2 yolk sacs. And this is more than 6 millimeters. So the number of yolk sacs doesn't predict the amnionicity in early first trimester, especially in the monochorionic twins. So in monochorionic twins, you have to look further inside to again label the twins. Sometimes when we do the scan at between 6 to 7 weeks, we come across this as 2 yolk sacs and something in between, but these are not 2 yolk sacs. One is yolk sac, the other one is the amniotic sac. And the center structure is nothing but the fetal pole. Once you tilt your probe, you can see the fetus is inside the yolk sac, and this is called as double blood sign. Here we can see 2 sacs and 2 amniotic cavities clearly, so dichorionic, diamniotic twins. And this one, monochorionic, diamniotic, you can see the membrane is so thin, and here at the attachment with no intervening chorionic tissue. This is a T sign, what we call it. And this is the monochorionic, monoamniotic twins. We can see them close to each other. So the next structure to see is the embryo. So once we see the embryo, we will start measuring it. But the events in the first trimester are so fast that an invisible embryo at around 5 weeks becomes a visible with head and trunk differentiation with the limb buds. So this is the structure which should be measured to assess the gestational age. So to assess the gestational age, we have to follow the rules. That is, you have to use the correct ultrasound plane. The endpoints of the measurement should be precise, and your gain and focus should be optimized. So it is a mid-sag, neutral or resting position is not difficult because the fetus is very small, but you have to take the linear measurement, and yolk sac and extremities should not be included in your measurement. So this is how we have to put our calipers, and this is how we have to measure the fetus. We should not include the yolk sac in your measurements. And this is the picture which usually we take the CRL measurement, but this is a coronal view, so we should avoid taking CRLs in this view, and we should take it in the sagittal views. So once you get a CRL plus 6.5 gives a gestational age in weeks. Again, the ideal time for assessing the gestational age is not too early. We have to wait at least till 10 weeks to assess the gestational age. The final thing which tells the pregnancy is viable or not is the heartbeat. The heartbeat in the early pregnancy is little low, but it gets settled by around 10 weeks. In the early pregnancy, we see something cystic structure in the cranial part of the fetus. We should not call it as some abnormality or anencephaly because we won't see such things so early. This is nothing but a rhombencephalic vesicle, which is the future brain. Again, we see the omphaloceles. So to say what is an physiological omphaloceles, the CRL should be less than 48. So if it is less than 48, that fetus is less than 11 weeks. Then you can see the cord incision at the tip of the omphaloceles sac, and even the color is at the tip, and the diameter should be less than 5 millimeters. So when you call a pregnancy as abnormal, it can be by the location, a low placed or an ectopic, sac size which may be too large or too small, and the contents of the sac. So we can see here the sac is nicely implanted near the fundus, but the other one is just above the cervix. So the low placed sacs again doesn't have a good prognosis. And here we can see this sac is very lateral, but we can see here there is communication with the endometrial cavity. This is a lateral implantation. And here we can see the implantation is lateral, but there is no communication with the endometrial cavity, and this is an corneal pregnancy. So we can see the difference between, because both of them look alike when we do early pregnancy scans. When there is communication with the endometrial cavity, there's nothing much to worry, but when the communication between the endometrial cavity and the sac is not there, then it is something which needed to be worried. Sometimes uterine anomalies which are not diagnosed before can be diagnosed because of good decidualized endometrium. It itself shows us the uterine anomalies. And cervical pregnancy, most of us when we do the scan, we just put the probe inside and trying to search in the cavity, but it can be in the cervical canal. And because of increased incidence of post-cesarean pregnancies, we are even seeing the cesarean scar pregnancies. And what is this? Is it a dichorionic? You can't. Please tell. What is the chorionicity of this pregnancy? This is a heterotrophic pregnancy. So we can see one, and there is some gap between the fundus and this, because this was reported as dichorionic pregnancy in a very early pregnant scan. When she came back symptomatic to us, it was a heterotrophic pregnancy. And this one? Twins inside and one outside? No, these are hyperstimulated ovaries. This is a situation because these are the people with the ovarian stimulation who have most of the time the multiple pregnancies, and the hyperstimulated ovaries are again vascular, and it is very difficult for us to diagnose, and so many times we overdiagnose or we underdiagnose, so we have to see the clinical situation and go about it. So make sure the gestational sac is in the upper half of the uterine corpus, and document at least one image of the whole of the uterus with the gestational sac communicating with the endometrial and endocervical canals. This is very, very important when you're doing an early pregnancy imaging. Why I'm insisting on this? Because these early pregnancy scans most of the time are done in the office by the gynecologist itself. Very rarely they come to us for a scan. So coming to the abnormal intrauterine contents, when you see the gestational sac empty without any fetal pole or yolk sac, we call it as a silent miscarriage. Or sometimes we see a fetal pole but without a cardiac activity, we again call it as a missed miscarriage. But when do we really have to call? Because different societies have got different opinions about this. By the Royal College, they say mean sac diameter is 20 millimeters, but American College, they say mean sac diameter of more than 16 millimeters. And again, there is some difference in the CRL. Some say it is 5, some say it is 6. But all this data is not sufficient for us to say, and because we may diagnose a wanted pregnancy as abnormal and try to terminate. So the recent guidelines say it is 25 millimeters of mean sac diameter. Mean sac diameter doesn't mean it's a one measurement. It is a 3 measurements which are taken orthogonal, which gives a mean sac diameter, and the CRL of at least 7 millimeters. Usually we take the interval growth 7 days apart. Now they say we have to wait at least 10 days. If there is no growth, then only you call it as miscarriage. And once the miscarriage is diagnosed, usually we give treatment and they come back to us to know whether it's a complete miscarriage or an incomplete miscarriage. In a complete miscarriage, the endometrial thickness will be less than 15 millimeters, and there is no evidence of retained products of conception. We can see thin endometrial strip like this. But in incomplete miscarriage, the endometrial thickness may vary, but if you see any heterogeneous mass with or without a sac, we call it as incomplete miscarriage. So there's another term called as first trimester oligohydramnios. This is a bit controversial, but when the mean sac diameter minus CRL is less than 5 millimeters, we see most of the time the pregnancies end up in miscarriage, and this is the only pregnancy in the 7 years I saw actually going to term. And the first trimester oligohydramnias, we don't know why it happens, but this is a picture most commonly we see when there is missed miscarriages. There will be so much of discrepancy between the sac and the fetus. And the next one is a vanishing twin. This is the death of one of the member of the twin in multiple pregnancy. Here we can see triplets, and all three fetal heart rates are noted. And then she had a follow-up scan where only 2 fetuses heartbeat is seen and 1 the heartbeat is not there, but in between she had a complaint of bleeding per vagina. So we could see this picture. This is nothing but the intrauterine hematoma. It's a crescent-shaped echo-free area between the chorionic membrane and the myometrium. So when do we give importance to the intrauterine hematomas? So which are the hematomas which cause problems? It's the location, position, and volume. So when it is retroplacental, see, we can see the basalis is elevated, and if the volume is more than 50% of the gestational sac volume, then the pregnancy outcome in this is poor. So we cannot end the lectures of abnormal intrauterine contents without the gestational trophoblastic diseases. These are proliferative abnormalities. We can see here partial mode, the sac is seen. Most commonly this is seen along with the missed abortions. We can see the increased chorionic reaction and the legs here. And this is a complete mole. There is no fetal tissue, but we can see nice nostrum appearance. So coming to the detection of anomalies before 11 weeks is really question mark, and we can actually suspect anomalies. We cannot diagnose anomalies so early. This is one of our case. At 9 weeks, we could see there is abnormal curvature. I was not able to take a proper CRL because the posterior aspect was not at all regular. The repeat scan at 11 weeks showed the nice kyphoscoliosis of the fetal spine. And this is another case at 10 weeks. Again, the CRL was very difficult to take, and when the color was put, it was not at the top, it was lateral to the defect, and the defect was seen. But we asked for a repeat, we did a repeat scan around 13 weeks, and the nice kyphoscoliosis, head is irregular, and the defect was so obvious here. And this is another one which I showed earlier, discrepancy in the CRL. At the same time, the yolk sac also is abnormal. One is big, more than 6 millimeters. This is a monochorionic twin pregnancy, discrepancy in the size of the CRL, size of the yolk sac. At 11 weeks, one is an anencephalic twin. And this is another pregnancy. There is edema all around the fetus, but to say it is an increased nuchal edema, the CRL was less than 48. So we just waited for a week. Again, everything resolved. And this lady, we have done a karyotyping, that was normal. She had a normal delivery, a female healthy baby. So the take-home message is, we have to wait at least 8 to 10 weeks for dating or for naming the multiple pregnancy, and wait and watch policy is very, very essential, and a follow-up scan at 11 to 13 weeks is needed, because many of the anomalies can resolve and only some can evolve as anomalies. Thank you.
Thank you, Dr. Sridevi, for your excellent lecture. Now I request Dr. Geeta to hand over the memento to Dr. I request Dr. Geeta to hand over the memento to Dr. Kivf Sridevi. Next lecture is Recurrent Pregnancy Failure, What is Done and What Not by Dr. P. Kavita. Dr. Kavita graduated in medicine from MRMC Gulbarga, MD in obstetrics from SV Medical College, Tirupati 2002, and practiced as a gynecologist at Saganlal Memorial Hospital, Hyderabad. Delivered a lecture on unexplained infertility at an annual conference hosted by the Obstetrics and Gynecological Society of Visakhapatnam 2009. And she participated in the clinical research project Significance of DNA Fragmentation in Male Factor Infertility, and presently consultant infertility specialist at Krishna IVF Clinic, since 2008.
Recurrent pregnancy is a distressing condition to the couple who expect answers and solutions, and it is also a vexing problem to the treating physician as he does not have answers in the face of ever-changing and conflicting recommendations. By definition, it is 2 or more failed pregnancies before 20 weeks of gestation which are documented either by ultrasonography or histopathological examination. I'll be discussing about risk factors for this condition and evaluation of this condition, what is to be done and what is not needed. Well, clinically recognized spontaneous miscarriages are seen in almost 15 to 25% of the pregnancies. And most of these pregnancy losses are due to structural chromosomal abnormalities in the fetus. In contrast, less than 5% of the women will experience 2 consecutive pregnancy losses, and 1% of the women will experience 3 or more consecutive pregnancy losses. Recurrence suggests a persistent cause. As a doctor, we are needed to identify it and treat the condition and give an answer to the couple. And risk factors for this condition are epidemiological factors, antiphospholipid antibody syndrome, genetic factors, anatomical factors, endocrine or metabological disorders, thrombophilia, autoimmunity, and other causes like infection, lifestyle, sperm quality. And cause is unexplained in up to 50% of the cases. Moving on to the epidemiological factors, maternal age and number of previous miscarriages are the 2 independent risk factors for pregnancy loss. And as age advances, the risk for increased recurrent pregnancy loss increases. And the risk is around 15% before 35 years of age, and it becomes 25% after 35 to 39 years. And it is around 50% after 40 years of age. And the reason for this increased risk is abnormal meiotic spindle formation and function, which leads to aneuploid oocytes and increased risk for recurrent pregnancy loss. Number of previous miscarriages also increase the risk for subsequent miscarriage. And at first pregnancy, the risk of miscarriage is only around 5 to 13%. And as pregnancy losses increase, at the end of 3 successive pregnancy losses, the risk is around 31 to 45%. Moving on to antiphospholipid antibody syndrome. This is the most important treatable cause for recurrent pregnancy loss. And surprisingly, the antibodies are present in 15% of the women with recurrent pregnancy loss. And in women with this recurrent pregnancy loss, associated with these antibodies, the live birth rate is only 5% if no pharmacological intervention is given during their pregnancy. And evaluation of this condition is needed with a history of 3 or more miscarriages, or before 10 weeks of gestation, or 1 or more morphologically normal pregnancy losses after 10 weeks of gestation, or 1 or more preterm births, that is before 34 weeks of gestation, the cause being a placenta. Moving on to the genetic factors with increased risk for recurrent pregnancy loss. They are either they are parental chromosomal translocations, embryonic chromosomal abnormalities, or single gene defects, or multifactorial. Approximately 2 to 5% of the couple with the recurrent pregnancy loss, they carry a chromosomal abnormality. Either it could be a balanced translocation or it could be a Robertsonian translocation. As you can see in this slide, there's a Robertsonian translocation between chromosome number 13 and 14, and here is a balanced reciprocal translocation between chromosome number 5 and 10. Although carriers are phenotypically normal, their pregnancies are at increased risk for miscarriage, stillbirth, and live birth with congenital abnormalities. And a Japanese study was conducted on 1,284 couples with recurrent pregnancy loss. In their study, they have noticed higher miscarriage rates in these conditions when male is a carrier for abnormal karyotype. Moving on to the embryonic chromosomal abnormalities. Fetal chromosomal abnormalities are the most common cause for any single miscarriage. And fetal recurrent aneuploidy, this condition appears to exist with up to 2 to 3 pregnancy losses. But as number of miscarriages increase, the risk for euploid pregnancy loss increases. And the risk of miscarriage due to embryonic abnormality increases with advancing maternal age. Do endocrine conditions cause recurrent pregnancy loss? Well, but well-controlled diabetes and corrected thyroid dysfunction and hyperprolactinemia, they do not cause pregnancy loss. But uncontrolled diabetes mellitus with a high value of HbA1c and uncorrected thyroid dysfunction and hyperprolactinemia, they do have a role in recurrent pregnancy loss. Women with PCOD have an increased risk for recurrent pregnancy loss, predominantly in the early gestation. And the risk exact mechanism is not clear. But the risk is attributed to insulin resistance, hyperinsulinemia, and hyperandrogenemia. And elevated free androgen index in these women seems to be a good prognostic factor for the subsequent pregnancy loss. But increased LH levels, they do not predict any pregnancy loss. Moving on to the anatomic factors, uterine anomalies, intrauterine synec, uterine fibroids and polyps, and cervical weakness do have a risk for recurrent pregnancy loss. And the exact mechanism, exact contribution of anatomical factors for this recurrent pregnancy loss is unclear. But according to a review of large number of studies, congenital uterine anomalies are seen in 4.3% of the normal women, fertile women, and 12.6% of the women with recurrent pregnancy loss. And the range is around 1.8% to 37.6%. And most of these pregnancy losses due to anatomical factors happen in the second trimester, except for septate uterus, wherein we see first trimester pregnancy losses more commonly. And septate uterus being the most common cause for recurrent pregnancy loss in anatomical factors. An interesting study was conducted on hysteroscopic findings in 80 of the women with recurrent pregnancy loss in Malaysia. And according to this study, they found out that septate uterus was the most common cause for recurrent pregnancy loss, followed by submucous fibroid. And they found in their study 13% of the women had normal hysteroscopic findings. Moving on to the inherited thrombophilia. Factor V lead-in mutations, protein C and protein S deficiencies leading to thrombophilia, they are also attributed as possible causes for recurrent pregnancy loss and late second trimester losses. And the mechanism is thrombosis of the uteroplacental bed. According to the meta-analysis of case control and cohort studies, antithyroid antibodies and antinuclear antibodies are evolving as risk factors for recurrent pregnancy loss. But further studies are indicated and needed to prove the association. So routine testing is not advised nowadays for this, the antiphospholipid and antinuclear antibodies. Altered uterine NK cell activity and altered cytokine activity have also been blamed as causes for recurrent pregnancy loss. But meta-analysis has concluded that available data is not consistent with more than modest association between these above factors and recurrent pregnancy loss. So testing is not offered routinely. Moving on to the infections. Role of infections in recurrent pregnancy loss is unclear. Infections leading to bacteremia and viremia, they cause sporadic miscarriages. But to cause a recurrent pregnancy loss, the organisms should remain in the genital tract without being detected and without causing any symptoms to the woman. And unfortunately, TORCH group of infections, they do not fulfill this criteria. So TORCH group of infections are not implicated as cause for recurrent pregnancy loss. So according to the RCOG guidelines, routine TORCH screening need not be done in recurrent pregnancy loss. Moving on to the obesity. Obese women have an increased risk for recurrent pregnancy loss. And spontaneous miscarriages are 7% higher in these women when compared to normal women. And the association is strongest in morbidly obese women where the BMI is more than 40%. And the increased risk for recurrent pregnancy loss may be linked to generalized increase in the systemic inflammatory response in these women. This is an interesting slide. This slide summarizes the effects of obesity on hypothalamo, pituitary and ovarian axis, and it also shows the reproductive potential of a woman in with obesity. Through cumulative impairment of several processes, obesity exerts its effect on fertility. It affects ovulation, oocyte maturation, endometrial development, uterine receptivity and implantation, and leading to most of the times miscarriages. Most of the studies conducted till date have focused mainly on female factor as a cause for recurrent pregnancy loss. Recent studies have demonstrated the association of male factor with recurrent pregnancy loss. And the factors considered here are paternal age, abnormal sperm morphology, sperm aneuploidy, and high DNA fragmentation rates. And I think we had extensive lectures about these factors as probable causes for recurrent pregnancy loss. So I'm not going in detail about these factors. Moving on to unexplained recurrent pregnancy loss. No apparent causative factor was seen in 50% of the couple with recurrent pregnancy loss. And chances of future successful pregnancy is about 50 to 60% in this couple, depending on the maternal age and parity. An interesting study was conducted in Denmark on chances of live birth rate in women with recurrent pregnancy loss. The study is shown in these graphs, and according to this study, younger women and women with less number of recurrent pregnancy losses had a better chance for live birth rate compared to their older women and women with higher number of pregnancy losses. And most of these women achieved live birth rate within 5 years from their first consultation. Moving on to evaluation. Evaluation should always begin with a history, especially the detailed history about the previous pregnancy losses, taking into account the gestational age at which the pregnancy loss has happened and the characteristics of the pregnancy, whether they were able to see a fetal heart or they were able to see a crown rump length, a fetal node, followed by menstrual history, physical examination. According to the RCOG guidelines and ASRM recommendations, all women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriages should be screened for antiphospholipid antibody syndrome. And this syndrome is identified, diagnosed, in fact, with 2 positive tests done at 12 weeks apart, and the antibodies tested are lupus anticoagulant and anticardiolipin antibodies. Medium or high titers over 40 grams per liter or above 90th percentile is considered as positive for this test. According to the RCOG guidelines, ASRM and Escher committee opinion, cytogenetic analysis on products of conception should not be performed as a routine care. Analysis may be useful in the setting of ongoing therapy for other identified remediable causes of recurrent pregnancy loss. And evaluation of cytogenetic analysis is helpful to identify if the event is a random or treatment failure. And limitations with the cytogenetic analysis are maternal tissue contamination, failure of culture growth, and failure to seek other causes. A study was conducted in Japan on chromosomal pattern of products of conception in recurrent pregnancy loss. According to the study, normal chromosomal pattern was identified in almost 70 to 80% of the couple with recurrent pregnancy loss. Evaluation is indicated now for the parental karyotype for balanced translocations in couple only with risk factors like 3 or more number of miscarriages, younger age of the woman at the second miscarriage, and recurrent miscarriage in the parents, either of the parents, and recurrent miscarriages in either of the siblings. And according to the RCOG guidelines again, all women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriages should have a pelvic ultrasound to assess the uterine anatomy. And if suspicious of any uterine anomalies, they may require further investigations like hysterosalpingography, 3D ultrasonography, MRI scan, and laparoscopic guided hysteroscopy. And according to the recent guidelines, thrombophilia screen for recurrent pregnancy loss is done only in high-risk women That is, women with history of thrombosis, or women with first degree family members or with thrombosis or inherited thrombophilia. And this is the standard operating procedure chart which we follow in our center. At first consultation, we try to fill in all these details which are available now, and then we plan what has to be done and what need to be done next for them. To conclude, recurrent pregnancy loss affects 1% of the couple and causes unexplained in 50% of them, and most of the women have good prognosis for eventually having a successful pregnancy. The chances up to 50 to 60% in them. And what to be done is detailed history and physical examination, hormonal assay for thyroid and prolactin along with GTT, screening for antiphospholipid antibodies, pelvic ultrasonography, and if needed further evaluation, parental karyotyping, semen analysis, and DNA fragmentation. Especially we do this at our center because most of the times the recurrent pregnancy losses we get are associated with secondary infertility. And what is not needed as a routine is routine fetal karyotype, TORCH screen, thrombophilia screen, NK cell activity and cytokines, antithyroid antibodies and antinuclear antibodies. These two aspects need further investigations, and follicular stimulating hormone estimation. Thank you.
Thank you, Dr. Kavita, for your clarity regarding the investigations needed in the recurrent pregnancy loss. Now I request Dr. Geeta to hand over the memento Dr. Kavita. Next lecture is Fetal Loss, Need to Establish Diagnosis by Dr. Sunil Jaiman. Dr. Sunil Jaiman, MD Pathologist, joined Fernandez Hospital, Hyderabad in March 2010 after having worked as a specialist pathologist in Denmark at the Institute of Pathology Regional Hospital, and the purpose of joining Fernandez Hospital was to organize perinatal pathology as a specialty. He has 21 faculty invitations and an expert speaker and panelist for various international and national conferences. Dr. Sunil has 16 presentations in international and national conferences, including those in Randers, and 7 of his presentations awarded a gold medal. He has 10 international and national professional and society memberships. He is one of the founder of life members of Association of Practicing Pathologists. He has 7 publications in peer-reviewed international and national journals. He is conducting 4 research projects on placenta, including one funded the Department of Biotechnology, Government of India. A research project on placenta has been initiated as recent as on the 16th October 2013 with Oxford University, UK and University of Oslo. Welcome, sir.
Thank you, Dr. Raju and Dr. Sridevi for inviting me to this gorgeous city. It's such a beautiful, vibrant city. I've come here for the first time and it was instant love. It is really beautiful. The previous speaker, Dr. Kavita, has elucidated and she has told us about recurrent pregnancy loss and various modalities to evaluate recurrent pregnancy loss. But one particular point she forgot was the role of a pathologist in establishing a recurrent pregnancy loss. We play a small role. We work behind the scenes. We do not interact so much with the patients, but we interact with you, the clinicians. And recurrent pregnancy losses less than 20 weeks, but more than 12 weeks can be evaluated and a diagnosis can be rendered which can help the clinician in subsequent pregnancies. Before we start, I always dedicate our work. We as pathologists, we cannot, directly heal the patient like you all do, but we work very diligently to establish a diagnosis, and we hope that by doing that, we provide some comfort to the patients. We are also inspired by Mother Teresa, who says, we do not do great things. As a perinatal pathologist, we work with small babies, which are not, not big babies, small babies, but we work with a lot of love. This is our center in Hyderabad, and This is a frog, you know, that's me, a frog in a well. The city is beautiful, the food was beautiful, very tasty. Now, if I put you off to sleep or if I fall off sleep, then it's not my fault.